Hello, good morning. This is a presentation of a clinical case, open right hepatectomy in a patient with hepatocarcinoma and pulmonary hypertension. I am anesthesiologist and I'm from Mexico. The liver resection is the most effective treatment for primary and secondary malignancies, but the major limitation of liver surgery is the high morbidity and mortality related to blood loss and liver function. The difficulty of the procedure and preparative management may increase due to the association of comorbidities, such as the present case when our patient have had hepatocarcinoma and pulmonary hypertension. The liver cancer is the fifth most commonly diagnosed cancer in population in worldwide. Various factors may limit the possibility of surgical resection. Just the 10 to 37% of the patient with hepatocarcinoma could be offered with the curative hepatic resection. This is the case report. A 64-year-old female with a diagnosis of hepatocarcinoma scheduled for right hepatectomy. She has a history of a chronic obstructive pulmonary disease, systemic arterial hypertension, and pulmonary arterial hypertension. The echocardiogram shows preserved left ventricular ejection and significant pulmonary arterial hypertension, but the liver and kidney function tests were normal. So they did the hepatectomy. Right hepatectomy is performed under the balanced general anesthesia with invasive monitoring, arterial line, and central venous pressure monitoring. We lowered the central venous pressure to 5 through fluid restriction, furosemide intravenous, other medication, and increase in the concentration of hypnotics like propofol, dexmedetomidine, fentanyl. Norepinephrine and milrinone infusions are maintained from the beginning until the end of procedures. The surgery did 4 Pringles with a total duration of 46 minutes. The bleeding was 1,700 milliliters. Then resuscitation was performed with 1,000 milliliters of crystalloid, 6 globular units, 2 fresh plasma, and bicarbonate. The surgical duration was 5 hours, and post-surgical resuscitation arterial blood gases are shown in the table 1. The patient was extubated without complication and transferred to the intensive care unit. The patient has adequate evolution, and the laboratory without data of liver failure discharged to her home after 10 days. Well, we have that blood losses of more than 10 liters have been reported in major liver resection. However, modern multimodal preparative techniques like new bipolar coagulation, ultrasonic aspirator technologies, hemostatic agents, advanced anesthetic monitoring, all that can have reduced the losses to just 300 and 900 milliliters. Strategies to reduce intraoperative bleeding, including low central venous pressure, the use of antifibrinolytics like tranexamic acid, we use that in this case, and some vascular occlusion techniques like Pringles maneuver is effective in reducing blood loss. But we always have a but. The prolonged application of Pringles maneuver may have a deleterious effect on liver function. Some patients can suffer of hepatic failure. Milrinone can maintain the low CVP, central venous pressure, with the benefit of better hemodynamics than nitroglycerin, other medication. Preparative mortality remains significantly higher in patients with pulmonary hypertension, like this patient. Cardiac output should be optimized preparatively by controlling right ventricular preload and afterload with inotropic support, like in this case. We used milrinone, started along with norepinephrine since induction till the end. Norepinephrine is a first-line treatment and improves coronary blood flow in models of right ventricular failure. This is the image of a piece of liver, right hepatectomy. The conclusion is that morbidity and mortality in hepatectomies can increase due to patient comorbidities. Perioperative management is complex, but there can be successful results if the patient is approached appropriately and multidisciplinary. Thank you.